Let's talk about obesity and BMI coding. Getting this right is so much more than just a technicality. It's absolutely key for accurate patient records. But the official ICD-10 guidelines, well, they have some pretty tricky exceptions. So today, we're going to break down those rules step by step to make sure your coding is spot on and compliant every single time.
So right off the bat, let's tackle the one question that seems to trip up so many coders. When you see a BMI in the chart, you have to ask, where did it come from? Does it have to be from the provider, or can it be from a nurse? What about a dietitian? The answer you'll see is a fantastic exception to a standard coding rule, and we're definitely going to get to the bottom of it.
But before we can answer that big question, we really need to understand a core principle here. You see, correctly coding obesity isn't about finding just one single code. It's more like a partnership. It's all about pairing the clinical diagnosis with a specific measurement that gives it all the right context.
And this slide illustrates that partnership perfectly. On one side, you've got your E66 codes. Think of these as the what. It's the provider's official diagnosis, like obesity or overweight. Then on the other side, you have the Z68 codes. This is the how severe. It's that objective measurement, the body mass index, that backs up the diagnosis. You really need both for the complete picture.
Okay, let's focus on the diagnosis side of that equation for a minute and see how this all builds. We're going to start by taking a much closer look at those E66 codes and what they actually represent.
Now, what's really interesting here is just how specific you can get. You've got your straightforward codes, right? Like E66.3 for overweight or E66.9 for just a general unspecified obesity diagnosis. But you can also get super specific, like E66.01 for morbid obesity that's from excess calories, or even E66.2 for when it's tied to alveolar hypoventilation, which you might know as Pickwickian syndrome.
So here's the crucial takeaway from the official guidelines. If a provider documents obesity or morbid obesity, you code it. That's it, period. The guidelines just assume it's clinically significant by default. But notice what isn't mentioned here? The term overweight. And yeah, that has its own special rule.
And here is that rule. See, unlike obesity, you can't just code overweight because it's mentioned somewhere. No, it has to meet the official criteria for a reportable secondary diagnosis. And that means it has to be actively monitored or evaluated or treated during that specific encounter. It's a really critical distinction to know to avoid any upcoding.
All right, so we've covered the diagnosis part of things. Now let's circle back to our very first question and reveal the big exception to the rule. Who exactly is allowed to document that BMI value for us to code it?
And here it is. This is that aha moment. This is the exception that just breaks the mold. The diagnosis, your E66 code, that must come from the provider. That part is totally non-negotiable. But the BMI, the Z68 code, that can be pulled from the documentation of other clinicians who are involved in the patient's care. So yes, a nurse's note or a dietitian's assessment is totally valid documentation for that Z code.
Let's lock this in with something easy to remember. Just think of it as the golden rule for obesity coding. Provider for the diagnosis, clinician for the BMI. Seriously, if you remember that, you'll avoid one of the most common errors people make in this area. It's that simple, and it's that important.
Of course, coding is never that simple, right? There are always unique cases and special scenarios. So let's just quickly run through a few key rules you absolutely need to know when the situation isn't so straightforward.
Okay, first up, pregnancy. During a pregnancy, you do not assign BMI codes. Full stop. Easy enough? Second, if a patient's BMI is fluctuating during a stay, maybe because of a condition like malnutrition, you code the most severe BMI that was recorded. But, and this is a big one, you do not use BMI codes for weight changes that are just due to fluid retention, because that's not a true reflection of body mass. And finally, for pediatric patients, just remember you're using specific codes based on age and sex percentiles, not just the raw BMI number.
Whew, we've covered a lot of ground. So let's boil all of this down into a simple, critical coding checklist. Here are the top 3 things you absolutely, positively must remember.
Takeaway number 3. The diagnosis is sacred. Your E66 code for overweight or obesity must always be based on a clear diagnostic statement from the physician or another qualified provider. There are no exceptions to this one.
And at number 2, this is our golden rule we talked about. Don't forget that unique exception. You can, and you should, use the BMI that's documented by other qualified clinicians like nurses and dietitians to assign your Z68 code. Don't waste your time searching for a provider's note if a nurse has already documented it for you.
And your number one takeaway is this: always check for context. Before you just slap on that BMI code, take 1 second to scan for any special conditions. Is the patient pregnant? Is this a pediatric case? Is that weight change just from fluid overload? You gotta know, because these conditions change the rules entirely.
So as we wrap this up, I want you to really think about this. Whether it's the golden rule of who can document the BMI, or the specific criteria for coding overweight, or those special exceptions for pregnancy, which one of these guidelines is going to have the biggest impact on how you approach your coding tomorrow? Because that's how we turn this knowledge into real practice.